This video is to help you take care of yourself at home after your surgery. The information in the video is an overview. You will receive specific instructions from your healthcare team. If you have questions or concerns about this information, or if these instructions are different in any way with the other information you have received, please talk to your nurse. You've had major surgery. Your body will need time to heal. You may feel tired for 6 to 8 weeks after your surgery. It is important that you follow the activity instructions. Continue to exercise. Walk 4 or more times per day. You may walk up and down the stairs. Walk to the point of being mildly tired, but not to the point of complete exhaustion. It is better to get up a few times every day rather than getting very tired one day and then resting all day the next day. It is important that you stay active. This prevents pneumonia and will help your body heal. Continue your breathing and coughing exercises. Use your incentive spirometer 10 times every hour during the day. Continue these exercises for 4 to 6 weeks or until your next follow-up appointment. Do not lift anything more than 10 pounds for 4 to 6 weeks. Avoid strenuous activities that may overstretch your arm or shoulder muscles. This includes swimming, tennis, golf, or vacuuming. Do not drive until you are off narcotic pain medicines. Do not drink alcohol while you are taking pain medicine. Do not smoke or expose yourself to smoke. If you had a thoracotomy, begin arm exercises after lung surgery as shown on the handout. Do these daily. This will help to loosen the tight muscles and get your arm moving again. Begin slowly and increase the amount until you are at a comfortable level. In about 6 to 8 weeks, you should be able to use your arm and shoulder as you did before surgery. If you had the VATS procedure, you may begin with more intense exercise 2 weeks after discharge. You may lift 20 pounds several weeks after surgery and increase to 40 pounds as tolerated or as instructed by your physician. Full healing will still take 6 to 8 weeks. Before you go home, you will be given supplies to change your dressing and any additional supplies you may need. If you're currently getting oxygen, we will work to remove the oxygen before you are discharged. However, if you still require oxygen therapy, when you go home, the respiratory therapist will perform a home oxygen evaluation. If you qualify for oxygen, your case manager will meet with you and make arrangements for home oxygen. If you have questions about supplies, ask your nurse before you are discharged. Once you're home, do not lie flat. Keep the head of your bed raised like it was in the hospital, 30 degrees or more. Put a foam wedge under your pillow to raise the head of your bed. This wedge will be sent home with you at discharge. Your incision may look different or be in a different place than you see in the video, but the care is the same. There will be small strips similar to tape across your incision. Keep these strips on your incision until they become loose. Wash over the strips to clean the incision area. Wash daily with antibacterial soap and water. Look for redness, swelling, or foul-smelling drainage from your incision. These may be signs of an infection. When the strips become loose, you can take them off. If they're still on after 10 days, remove them. You will need to clean and monitor your chest tube site as well. Leave the chest tube dressing in place for 48 hours after the chest tube has been removed. After 48 hours, remove the chest tube dressing. Wash the site with antibacterial soap and water daily. Look for redness, swelling, or foul-smelling drainage from your incision. Again, these may be signs of infection. It is normal to have drainage from the chest tube site until the incision is healed. If the chest tube site is still draining fluid, Apply clean gauze and tape. If the chest tube site is no longer draining, you may leave it open to air. You may take a warm bath and swim 6 weeks after you are home. Your nurse practitioner or physician assistant will give you a list of medicines before you are discharged. The nurse will review each medicine with you. Be sure to take pain medicine regularly. Don't wait until you feel too uncomfortable. It helps to stay ahead of the pain. If you fall behind and your pain level increases, it can take longer to regain good pain control. It may be helpful to set an alarm clock. This will wake you at night to take your pain medicine. You may feel discomfort for 1 to 2 months. Your skin may feel numb, such as near your incision or nipple, for 4 to 6 months. The area around the nipple may also feel sensitive. However, your pain should lessen over time. During surgery, you may have gotten a long-acting pain medicine. This medicine will stay in your system for 3 or more days. As it wears off, you may become more uncomfortable. Do not be alarmed. You will have additional pain management options. Tell your doctor if you have a new pain or increased intensity in pain. Plan ahead. Be sure to call the thoracic center before you run out of pain medicine. Pain medication may cause constipation. Walk frequently. You will likely be sent home with a stool softener or laxative. Follow your medicine taper instructions. Weaning pain medicines is an individual process. Once you find that you do not need the extra medicine before the next scheduled dose, you can start to space out how often you take the scheduled medicine. Your team will help you decide which medicine to discontinue first. If your prescription is not covered by insurance or is too expensive, please call the thoracic center. Follow the diet plan from your dietitian. It is important to maintain your weight. Weigh yourself the day you get home, and then weigh yourself twice a week. Each time you weigh, keep a record of your weight. Your weight may vary from what it was in the hospital. If you develop nausea, vomiting, diarrhea, or constipation, contact your nurse, doctor, or dietitian in the thoracic center. If you experience constipation, you will be given a prescription for docusate sodium, which is a stool softener, and Senna S, which is a laxative. Stop taking stool softeners and laxatives if you develop diarrhea. Plenty of fluids and staying active help to prevent constipation. The jejunostomy tube, or J-tube, is a feeding tube used to deliver nourishment and medicines while you recover. The tube goes into your small intestine. Keep the tube secured with tape at all times to an area of skin just below the tube insertion site. This will prevent the tube from becoming dislodged. Cap the tube in between feedings. Clean around the tube with soap and water every day. Flush the tube with water before and after each use. If the tube comes out partially, gently slide it back in place and re-tape the tube to your skin. If the tube comes out completely, rinse the tube with tap water and gently reinsert it. If you cannot gently reinsert the tube, stop. Clean the insertion site with soap and water and place a clean gauze pad over the site. Tape securely. Rinse the tube off with warm water and place in a clean plastic bag. Call the thoracic center to have your tube reinserted. If the center is closed, go to the nearest emergency room. Take your tube with you to have it reinserted. Do not use your tube until placement has been verified by X-ray. If your tube is clogged and you cannot flush it, do not force the water into the tube. Instead, do the following. Check to make sure the clamp has been removed and there are no kinks in the tubing. Flush the tube with a water-filled syringe. Gently pull back on the plunger to dislodge the tube obstruction. Alternate pressure and suction. Milk the tubing with your fingers from the insertion site out. Try again to flush the tube using warm water, not hot. Do this gently to avoid dislodging the tube. If you still cannot flush the tube, mix 1 teaspoon of Adolph's meat tenderizer in 1 tablespoon of water. Using a 10 milliliter syringe, instill as much of this mixture into the tube as you can. Cap the tube and let the mixture stay in the tube for 15 to 20 minutes. Try to flush the tube again with water. If you still cannot flush the tube, call your clinic nurse, doctor, or dietitian. You will continue to take your medicines through your feeding tube. Add 30 milliliters of water to each dose of liquid medicine. Non-liquid medicines should be crushed with a mortar and pestle or pill crusher to a fine powder and mixed with 30 milliliters of water. Liquid medicines are less likely to clog the feeding tube than pills. If liquid medicines are not available, check with your nurse in the thoracic center to make sure that the pill can be crushed. Flush the tube with 30 milliliters of water before and after medicines are given through the tubing. Do not mix medicines with feeding formula or with other medications. Flush the tube with 10 milliliters of water between different medicines. Follow-up appointments are usually scheduled for 1 week and 1 month after surgery. At the first follow-up appointment, you may have a barium swallow and a chest x-ray. After the barium swallow, you will meet with a dietitian in the clinic for further diet instructions. Contact the thoracic center if you have pain not controlled with medicine. Develop a new cough or worsening cough. When you have constipation that does not improve with over-the-counter laxatives, or to receive pathology results. Call 911 or go to the nearest emergency center if you experience increased difficulty breathing, have a fever greater than 101 degrees Fahrenheit, worsening redness, swelling, or drainage from your incisions, foul-smelling drainage from your incision, have persistent nausea, vomiting, or diarrhea, or if you experience chest pain or constant palpitations. Refer to your discharge handout. Feel free to watch this video again through My MD Anderson. Thank you for watching. Remember, we're here to help.